We'll now see the applied anatomy of the median nerve. As we all know by now that the median nerve is formed by the lateral root and the medial root of the median nerve, which are the branches of lateral cord and medial cord of the brachial plexus. So this median nerve is formed in front of the third part of the axillary artery in the axilla, and then continues on to the flexor compartment of the arm. Being a content of the cubital fossa, it enters into the forearm, supplying all the flexor muscles except flexor carpi ulnaris and the ulnar side of the flexor digitorum profundus, supplying all other muscles of the forearm, and then through the carpal tunnel it enters into the palm, supplying the thenar muscles and first and second lumbricals, and the cutaneous supplied to the lateral 3.5 fingers. This is the posterior view of the upper limb, where the median nerve is not concerned for the posterior compartment or the extensor compartment, median nerve being the flexor compartment nerve of forearm and hand. So the injuries to the median nerve can take place at elbow, at mid forearm, at the distal end of the forearm, and in the carpal tunnel. So based on these lesions, the lesions of the median nerve are classified as high median nerve lesions and low median nerve lesions. So the lesions which are above the mid forearm are considered as high median nerve lesions, and the lesions below the mid forearm or the lesions concerned with the distal forearm and in the hand are considered as low median nerve lesions. So the lesions in the axilla can be due to crutch compression and also due to anterior dislocation of the shoulder. And in the upper arm, they may be due to the stab wounds or the fracture of humerus shaft, that is the diaphysis, which can be supracondylar fracture also. So in the arm, the compression can be due to the supracondylar spur, the Struthers ligament, and the lesions at elbow are due to the fracture of the supracondylar region in the children. That is mainly due to the outstretched hand, fall on the outstretched hand, and a fracture of the medial epicondyle and elbow dislocation, or maybe thickening due to the bicipital aponeurosis, or maybe due to its entrapment between the both the heads of the pronator teres, that is the superficial and deep heads of the pronator teres as well. And it can even get compressed as it enters into the forearm in front of the elbow underneath the arch of the flexor digitorum superficialis. And it can even get compressed by the abnormal pronator teres bands that join with the eponeurotic arch of the flexor digitorum superficialis. So these are all considered as high lesions. And when we come to the low median nerve lesions, they usually occur at the distal third of the arm or in the carpal tunnel. So the cuts in the distal part of the front of the wrist, that is the suicidal cuts according to the forensic terminology, that can injure the median nerve, and it can get compressed in the carpal tunnel by the thickening of the flexor retinaculum or any inflammation to the radial or ulnar bursa, which wrap the long flexor tendons of the forearm or any carpal dislocation. Usually it is the lunate dislocation that happens to compress the median nerve, decreasing the space within the carpal tunnel. Now let us see the comparison of signs and symptoms of the low lesion and to the high lesion. So in the low lesion, that means at the injury to the median nerve at wrist and in the carpal tunnel, there is wasting of the thenar eminence, the abduction of the thumb is lost, opposition movements of the thumb are lost, and the lateral 3.5 fingers sensations on the palmar surface is also lost. And in the high lesions, all these signs of the low lesion plus wasting of the lateral aspect of the forearm is seen, and the OK sign like this cannot be performed because the deep muscles of the forearm lose their nerve supply and their function, and pointing finger is seen. That is, there is loss of flexion of the interphalangeal joints of the index finger, which is more pronounced because of the unopposed action of the extensor digitorum along with the extensor indicis as well. When a person is asked to make a fist, that will project as a pointing finger. So when a patient comes with the signs and symptoms of the median nerve injury or the lesions, the main things to be considered are to look at the flattening of the thenar eminence. So that is because of the wasting of the thenar muscles, and the flattening of the pulp of the thumb as well as the index and middle fingers can also be seen. And the patient is asked to feel the prick or touch sensations in this lateral 3.5 digits and in the palm and thenar eminence. And the patient is asked also to abduct the thumb against resistance and oppose the fingers, like touching the pulp of the other 4 fingers. So all these movements are lost if there is any median nerve lesion or injury. So the localization of the lesion very much depends in projecting the signs and symptoms. So which means that the signs and symptoms vary according to the injury of the median nerve at different levels in the upper limb. So the lesions in the axilla, upper arm and elbow cause the following, or we can say that the injury to the median nerve before it gives its muscular and its anterior intractious nerve branches. This is called as median neuropathy, and in the axilla the injury to the median nerve may be due to the usage of crutch or due to the fracture of the shaft of the humerus in the upper arm, or maybe due to the stab injuries in the arm or at the elbow, can also usually injure the ulnar and radial nerves too, which is called as triad neuropathy. In this condition, there is paralysis of all muscles that are innervated by median nerve. That means all the flexor muscles, both superficial and deep, of the forearm, and the thenar muscles and first and second lumbricals are paralyzed. So when median nerve at this level is injured, everything is affected that is concerned with the median nerve. So the pronation of the forearm is totally lost, as the pronator teres and the pronator quadratus are damaged or paralyzed. And the superficial flexors are paralyzed, which leads to the loss of flexion at wrist. So the palmaris longus, flexor carpi radialis and flexor digitorum superficialis are paralyzed, causing the loss of flexion at wrist. In addition, when the flexor carpi radialis is paralyzed, there is ulnar deviation of the wrist because of unopposed action of the flexor carpi ulnaris and extensor carpi ulnaris. And along with the loss of flexion at wrist, because of the damage to the flexor digitorum superficialis, there is loss of flexion of second phalanges of all digits, because the flexor digitorum superficialis tendons, the 4 digital tendons to second, third, fourth and fifth digits, are inserted at the base of the middle phalanx. Coming to the deep muscles of the forearm, the flexor pollicis longus loses its flexion at interphalangeal joint as well as metacarpophalangeal joint of the thumb, as it is inserted at the base of the terminal phalanx of the thumb. As the radial half of the flexor digitorum profundus has its supply by the anterior intractious nerve, which is a branch of the median nerve, the flexion of the terminal phalanges is lost for the index and the middle fingers, along with faint flexion of the wrist is also lost, which is contributed by the flexor digitorum profundus, the radial half. And when we come on to the hand, the thenar muscles are all paralyzed, causing the wasting of the thenar muscles, because the thenar muscles function is lost and there's flattening of this thenar eminence that is seen. The opposition function of the thumb, that is touching the pulp of the other digits, is lost. Abduction of the thumb is lost. There is a faint flexion of the thumb is lost because this flexor pollicis brevis muscle, the deep head, has its nerve supply from ulnar nerve also. So the flexor pollicis brevis is a dual nerve supply muscle. And the first and second lumbricals function is also lost, which gives the clawing of the index and the middle fingers, and the sensory sensation of the lateral 3.5 digits on the palmar side and the dorsal cutaneous innervation of the lateral 3.5 digits till the middle phalanx of index, middle finger is lost, and only the terminal phalanx of on the dorsal side of the thumb is lost. So there is flattening that is seen in the pulp area of the thumb, index and the middle fingers as well. And this will give an impression of an ape-like hand because the thumb is adducted because abduction of the thumb is lost, and there is unopposed action of adductor pollicis, which is supplied by ulnar nerve. So the thumb is adducted, which gives an ape-like hand or simian hand deformity. And there is this benediction hand, where when a person is asked to make a fist, then the flexion of the index and middle fingers along with thumb is lost because of the paralysis of the lumbricals and the deep muscles of the forearm. So when we see the median nerve injury at elbow or at the wrist, the deformity that is seen as the ape-like hand, that is the flattening of the thenar eminence because of the atrophy of the thenar muscles, and the thumb you can say is adducted because the abduction of the thumb is lost, and the adduction of the thumb is more pronounced because of the adductor pollicis, which is supplied by ulnar nerve. And opposition movements of the thumb is also lost. So the person with this sort of injury, the median nerve injury, will not be able to button up the shirt or hold a pen. Here you can see between the index and the thumb, and the person will not be able to feel the structures with the thumb and index finger as well. So it no more functions as a peripheral eye. So because of the paralysis of these thenar muscles, the thumb remains extended and adducted because of the unopposed action of extensor pollicis longus and extensor pollicis brevis, and also the adductor pollicis. So this is how the hand of the median nerve injury patient will be seen. So if we look at what happens to the median nerve injury above the wrist and above the elbow. So when the injury is above the elbow, as we have seen before, the median nerve is injured before it is giving its divisions to all the flexors, both superficial and deep, of the forearm, and the thenar muscles are also affected. So there is loss of pronation, there is weak flexion because the flexor carpi ulnaris and the ulnar half of the flexor digitorum profundus are unaffected. There is ulnar deviation because of the unopposed action of the flexor carpi ulnaris and the extensor carpi ulnaris. Inability to flex the thumb because of the flexor pollicis brevis. Inability to oppose fingers because of the opponent's pollicis which is affected. Inability to flex the middle digits because of the injury and inefficiency of the functioning of the flexor digitorum superficialis, and inability to flex the terminal phalanx of the index and middle fingers because of the injury to the radial half of the flexor digitorum profundus. And there is sensory loss to the lateral 3.5 fingers, along with the sensory loss to the main part of the palm and the thenar eminence, and this gives an ape-like deformity to the hand. And this injury to the median nerve above elbow can happen because of the supracondylar fractures or any fall on the outstretched hand, or it may be due to the usage of crutch or any of the stab wounds, or it may be due to the supracondylar spur, or maybe due to the Struthers ligament, can be due to the thickening of the bicipital aponeurosis, or can be due to the entrapment of the median nerve between the two heads of the pronator teres as well. So coming to the signs that appear when the injury to the median nerve is just above the wrist. In this condition, the innervation to the long flexors of the forearm are all preserved. The only thing that is affecting is the thenar muscles and first and second lumbricals. So there is no loss of pronation, no weak flexion, no ulnar deviation, and no inability to flex the middle digits, no inability to flex the terminal phalanges of the index and middle fingers, and only thing that is lost is the functioning of the thenar muscles. That is, there is no abduction that can happen with the thumb. There is no opposition that is seen with the thumb to the other fingers, and there is a weak flexion because the deep head of the flexor pollicis brevis has its supply from the ulnar nerve, and the sensory loss is there to the lateral 3.5 fingers of the palmar side, and on the dorsal aspect till the middle phalanx, and only to the terminal phalanx of the thumb. So it depends on where the injury is at the wrist. That is, if it is just at the flexor retinaculum, the sensory loss is preserved to the thenar eminence or at the central part of the palm. If the injury is more proximal to the distal part of the forearm, then there can be the sensory loss to the thenar eminence as well as the central part of the palm also. So here the clawing is less pronounced, whereas when the injury is above the elbow, the clawing is more pronounced. Because of the injury to the thenar muscles, whether it is above the elbow or above the wrist, there is wastage of the thenar muscles causing flattening of the thenar eminence, which gives an ape-like deformity, ape-hand deformity. So this median nerve can get compressed at various sites, being the supracondylar process, the ligament of the Struthers, and the bicipital aponeurosis thickening, which is also called as lacteous fibrosis, between the superficial and deep heads of the pronator teres, under the aponeurotic origin of Flexor Digitorum superficialis, and it can also get compressed within the carpal tunnel, which is called as carpal tunnel syndrome. And anterior intractious nerve, which is a branch that is given off from the main trunk of the median nerve just distal to the pronator teres, can get compressed by the fibrous bands of the pronator teres. Here you can very clearly see. This is an abnormal fibrous band which is connecting the deep head of the pronator teres with the median nerve. So that is where the anterior intractious nerve can also get affected. And Flexor Digitorum superficialis origin bin, where the aponeurotic edge can compress the median nerve, and enlarged bicipital bursa, as the tendon of biceps. It inserts onto the radial tuberosity. There is a bursa that is intervening between the biceps tendon and the radial tuberosity. So that bursa can get inflamed, compressing the anterior intractious nerve. And it can also get compressed by cancer muscle, which is nothing but the accessory muscle or an extra belly of a muscle that is known as Ganser muscle. We will see what it is. Yeah, this is the Ganser muscle, the slender belly. It's an accessory muscle to the flexor pollicis longus. So it arises from a different area, but it blends with the main bulk of the flexor pollicis longus. As we have seen in the course that the anterior intractious nerve is lodged between the flexor pollicis longus and flexor digitorum profundus. This Ganser muscle, which is across this area, has also possibility of compressing the anterior intractious nerve. This is the accessory belly of flexor pollicis longus, which is called as Ganser muscle. And another clinical aspect which you have to know is the median nerve block. So any nerve blocks are given to perform any interventions, surgical interventions in the localized area of that nerve territory, the supply of that nerve territory. So if there is any surgical intervention that has to be done for the lateral 3.5 fingers and the central part of the palm or the thenar eminence, then the median nerve block can be given. So the anesthetic is injected, feeling for the median nerve just proximal to the flexor retinaculum between the palmaris longus tendon and the flexor carpi radialis tendon. When the anesthetic solution is injected here, it causes numbness of the area where the median nerve supply is there. Coming to the anterior intractious nerve syndrome. So any injury or compression to the anterior intractious nerve can cause this anterior intractious nerve syndrome. So this anterior intractious nerve, this one, which is the larger branch of the median nerve, supplies classically 2.5 muscles, which are the deep muscles of the forearm, which are the flexor pollicis longus, the pronator quadratus, and the radial half of the flexor digitorum profundus muscles. So the action of these muscles are hampered. As there are no cutaneous branches given out by the anterior intractious nerve, there is no sensory loss. So it is purely a motor syndrome. So the pain is felt in the proximal forearm, and there is mild paresis of the forearm pronation because the pronator teres is intact, and the paresis of the flexion of the terminal phalanges of second and third digits is lost because of the radial half of the flexor digitorum profundus loses its function, which sends its digits to the index and middle fingers. There is paresis of the flexion of the terminal phalanx of the thumb as well, because the flexor pollicis longus gains its insertion onto the base of the terminal phalanx of the thumb. So here what happens is, this can be due to the compression of the median nerve in between the two heads of the pronator teres, what you call it as entrapment syndrome of pronator teres, and flexor digitorum superficialis arcade, that is as it enters into the forearm. There is lacteus fibrosis, that is the fibrosis of the bicipital aponeurosis, enlarged bicipital bursa, and this Ganser's muscle. And the opposition of the fingers, the flexion here is more pronounced, or it is lost actually, of the terminal phalanx because of the flexor digitorum profundus and the flexor pollicis longus. So the flexion is lost, and this OK sign, what is done, cannot be properly performed in the anterior intractious nerve syndrome, as there is a loss of flexion at the terminal phalanx of the index and the thumb. And another most important thing to be known is this anterior intractious nerve can be used as a graft or a donor branch to re-innervate the paralyzed muscles that are innervated by the ulnar nerve. So now let us see each of these signs, how they are depicted. Hand of benediction, which is also called as Pope hand deformity. He is a Pope, and during his blessings, this is how the hand is seen, which is called as Pope's hand, and that is how the hand also appears in the median nerve lesion when a person is asked to make a fist. Then there is a loss of flexion of the index, middle, and the thumb digits. So this is called as Benedict's attitude. So this Benedict's hand, or the hand of benediction, is seen when the lesion to the median nerve is at the wrist or at the elbow. And this is because the lumbricals and flexor digitorum profundus tendons to the second and third digits are paralyzed. So this leads to loss of flexion at metacarpophalangeal joints and the distal interphalangeal joints. So when the patient is asked to make a fist, he can be able to flex the 4 and 5 digits, but not the radial 3 digits. So now what is this carpal tunnel syndrome? This is a common neurological problem associated with median nerve compression within the carpal tunnel, this one, beneath the flexor retinaculum at the wrist. So when there is compression of the median nerve in the carpal tunnel, it is known as carpal tunnel syndrome, which can be due to fibrosis of the flexor retinaculum, can be due to the inflammation of the radial and ulnar bursa, which wrap the long flexors of the forearm, and can be due to the carpal bone dislocations also. The most common one to dislocate is the lunate bone, which causes the carpal tunnel to become narrow, thus compressing the median nerve. So when such a compression is seen, so what are the features that are seen in carpal tunnel syndrome? So what are all that are supplied by the median nerve in a hand are affected? So all the thenar muscles along with first and second lumbricals are affected. So there is loss of abduction of the thumb, there is loss of opposition of the thumb to the pulp of the other digits, and there is a weak flexion of the thumb that is seen because the flexor pollicis brevis, the deep head, is supplied by the ulnar nerve. There is unopposed action of the adductor pollicis because it is also supplied by the ulnar nerve. So that is all the motor effects that are seen. And the first and second lumbricals, which are concerned with the tendons that are the flexor digitorum profundus tendons that are going to the index and the middle fingers, are also affected. So if we see here in this picture, these are the long flexor tendons, which are the flexor digitorum superficialis. You can see that it is inserted onto the base of the middle phalanx. This is the flexor digitorum profundus, which is inserted onto the base of the distal phalanx. And this is an extensor tendon, which is inserted onto the base of the distal phalanx dorsally. So before its insertion, the extensor digitorum, it modifies to form an extensor expansion or extensor hood, onto which the intractiae and the lumbricals gain their insertion. So these lumbricals, they arise on the long flexor tendon and they get inserted on to the long extensor tendon, connecting the flexors to the extensors. So these lumbrical muscles are called as link muscles. They are linking the flexor, long flexors, with the extensor tendons. So this lumbrical, as it gets inserted, it spans from the proximal part of, that is from the base of the extensor expansion to the apex. So as it crosses the metacarpophalangeal joint, it helps the functioning, or it contributes to the function of flexor digitorum profundus, as this insertion is ventral to the axis of the digit. At its insertion onto the extensor expansion, nearer to the apex of the extensor expansion, it helps with the action of extensor digitorum, as its insertion falls dorsal to the axis of the digit. So that is the reason the action of lumbrical is the flexion at the metacarpophalangeal joint, along with the action of the long flexor muscles, and extension of interphalangeal joints, that is because of the action of the extensor digitorum. So that is lost. So the flexion at metacarpophalangeal joint is lost, which happens to be the extension at the metacarpophalangeal joint, and is more pronounced because of the unopposed action of the extensor digitorum at the metacarpophalangeal joint. So there is hyperextension, we can say, at the metacarpophalangeal joint due to the median nerve injury, and the extension of the interphalangeal joints is lost. So there is flexion that is seen at the interphalangeal joint, giving a claw hand appearance. So when the clawing is seen for the index and middle fingers, it is called as median nerve claw hand. And as far as sensory changes are concerned, there is no there is numbness and tingling that is felt on the palmar aspect of the lateral 3.5 digits, as well as on the dorsal aspect of the skin of the index, middle and ring finger till the middle phalanx, and for the thumb it is only on to the terminal phalanx it is felt. The numbness and the tingling sensations, the burning sensations and pricking sensations, like it is classically said as pins and needle sensations. So the center of the palm and the thenar eminence are spared because the palmar cutaneous branch of the median nerve, which supplies the palm, the center part of the palm and the thenar eminence, is given out proximal to the flexor retinaculum, or in other words, before the median nerve enters into the carpal tunnel. Because there is no sensations for the lateral 3.5 fingers, there is drying and scaling of the skin is seen, and since the dorsum of the 3.5 fingers are also affected, the cracking of the nails is seen, and there is atrophy that is seen for the index, middle and the thumb fingers also. So to relieve all these symptoms, the median nerve compression can be relieved in the carpal tunnel by incising in the midline at the wrist between the thenar and hypothenar eminence over the flexor retinaculum to release the compression of the median nerve. The ape thumb deformity. So in this, it can be also called as ape hand deformity, which is mainly due to the median nerve injury at the elbow or at the wrist also. It can be seen where thumb is in adducted position, like even in ape you can see the thumb is adducted. It can't be abducted. So the abduction of the thumb is lost because of the abductor pollicis brevis, which is lost. So there is extension of the thumb because of the extensor pollicis longus, which has its unopposed action, and there is loss of opposition movement of the thumb to the pulp of the other fingers, and because of the loss of sensations, they show the trophic changes also, the pulp of lateral 3.5 fingers. There is slight clawing that can be seen for the index, middle and the thumb fingers, because of the loss of the sensation here, and it is more pronounced for the index and middle finger because of the loss of the lumbrical action, and this can also be caused due to leprosy and the polio. Since these are all peripheral nerves, the leprosy can also infect the median nerve. So this is how an ape hand can be seen like this. There is loss of abduction, the thumb is adducted, flattening of the thenar eminence, and the slight clawing that can be seen with the index and the middle fingers, you can see over here. So this is what is ape thumb deformity that can be noticed. So here it is, how do we test the median nerve injuries? So this can be tested by phalanx maneuver. When the injury is in the carpal tunnel, you should ask the patient to raise the arms to the shoulder level and flex the arms at the wrist so that the back of the hands approximate each other, and to be kept in this position for about 60 seconds. which causes the compression of the median nerve, causing the numbness and tingling sensations for the lateral 3.5 fingers on the palmar aspect as well as on the dorsal aspect till the middle phalanx for the index and middle finger, and only to the terminal phalanx for the thumb. So if the tingling and numbness is felt by this maneuver, then the phalanx test is positive, confirming the compression of the median nerve in the carpal tunnel. So the other test is Tinel's test. So by tapping the median nerve at the wrist over the flexor retinaculum or just proximal to the flexor retinaculum also causes tingling and numbness to the lateral 3.5 digits. So if by tapping over the flexor retinaculum the tingling and numbness is felt on the lateral 3.5 digits, it is said to be positive. The Tinel's test is said to be positive and is called as Tinel's sign, which again confirms the compression of the median nerve within the carpal tunnel. Another test is called as Osler's clasping test or the pointing index fingers test. So that when the patient is asked to clasp the hand together, the index finger and the thumb fail to flex on the median nerve lesioned side. Here you can see the flexion of the index finger and thumb of the normal side. So if this is seen, then it is called as pointing index finger or a positive Osler's clasp test. Inability to flex the terminal phalanx of the thumb and the index finger is due to the injury to the anterior intractious nerve, which causes inability of the function of the flexor pollicis longus, which is innervated onto the base of the distal phalanx of the thumb, and the flexor digitorum profundus, which is innervated onto the base of the terminal phalanx of the index finger. So the flexion at those terminal phalanges of index finger and thumb are lost, and there is unopposed action of the extensor pollicis longus for the thumb and the extensor digitorum as well as extensor indicis for the index finger. So that is more pronounced for the index finger, which is called as pointing index finger. If there is pointing index finger, that depicts the compression of the median nerve above the mid forearm or the injury to the anterior intractious nerve. So this is a very brief summary of the applied aspect of the median nerve. So when the lesions are above the elbow, maybe due to supracondylar fractures or applying a tight tourniquet during venipuncture, or maybe very simple thing like inflating a BP cuff to record the blood pressure. If the BP cuff is inflated for a longer time also, it causes numbness. So the motor deficit that can be seen due to the injury or compression to the median nerve is loss of pronation of the forearm, weakness in flexion of the hand at the wrist, and loss of flexion of the thumb, second and third digits, loss of abduction, position of the thumb, and the thumb is adducted and there is hyperextension of the index and middle finger at the metacarpophalangeal joints, and there is loss of sensation in the thumb, second, third digits and the thenar area as well. When the lesions is between the elbow and the wrist, that is in the middle of the forearm, which usually injures the anterior intractious nerve also, there is loss of pronation of the forearm that is seen, loss of flexion of the thumb, second, third digits, that is loss of the thenar muscle function, and the pointing index finger is more pronounced because of the unopposed action of the extensor digitorum and extensor indicis to the index finger, and the loss of abduction and apposition of the thumb are also seen, along with the loss of sensation as usual for the lateral 3.5 fingers and the thenar area. If the lesion is proximal to the carpal tunnel, that is due to the deep lacerated wounds, which are called as suicidal cuts in the forensic terminology, only the thenar muscles action and first and second lumbricals are affected, along with loss of sensation of the thumb, second and third digits on the palmar side as well as on the dorsal aspect till the middle phalanx for second and third digit, and only to the distal phalanx for the thumb, and in the thenar area also. When the lesion is within the carpal tunnel, then also it is the thenar muscle actions are lost along with first and second lumbricals, which gives an ape thumb deformity. Here a point to be noted is the sensory deficit is only to the palmar surfaces of the thumb, second, third digits, along with the cutaneous sensations that are lost on the dorsal aspect of second and third digits till the middle phalanx, and the dorsal aspect of the thumb for the terminal phalanx only, excluding the thenar eminence and the central part of the palm, because it has its supply from the palmar cutaneous branch, which is given from the median nerve before the median nerve enters into the carpal tunnel.